Once again, I'd like to welcome everyone to the Public Health PBRN monthly virtual meeting for July. This is Lisette Fowler, and Dr. Memorial and I will be your hosts for today. I will let CB do the introductions for this meeting, but just a quick reminder to please mute your computer speakers or your telephone speakers as well until the Q&A. CB, take it away.
All right, thank you, Lizette. Welcome, everyone. We are excited to have a great presentation ahead of us today from our Connecticut PBRN. We have Dr. Patricia Checco and Dr. Jeffrey Cohen who will be presenting and discussing some of the results from their delivery and cost study on the cost effectiveness, efficiency, and equity of inspection services throughout Connecticut's local public health system. So Pat and Jeff, we're happy to have you with us this afternoon, and we look forward to your presentation. So you have the floor.
Thank you, CB. Good afternoon, everyone. I'm going to start out to talk a little bit about the project itself and some demographics about Connecticut, and then Jeff will take over when it comes to the important stuff. So our project basically had two components, and we'll be talking primarily about component one today. The first was to describe and analyze the scope and cost of 4 environmental health services provided in Connecticut and the differences in associated costs incurred by local health jurisdictions that may arise from differences in the size and structure of the health department. The services we chose were 4 that are absolutely mandated either in state statute or through the public health codes, specifically food protection, public water well, subsurface, sewage disposal, and lead poisoning prevention and control. Component 2 is very different from the first. We will be using key informant surveys and focus groups with food workers to really try to zero in more on evaluating the impact and size and organization structure relative to a number of hypotheses around the efficiency, effectiveness, and equity of food protection services. So first, a little bit about Connecticut. First of all, you all remember we're one of the first 13 colonies. So we're small, but we're very dense in terms of population. This will give you an idea of our local health department and district structure in Connecticut. We are only outshined by Massachusetts in the terms of our decentralization of activities in Connecticut. We are divided into 3 types of health departments. There are part-time care departments, which we sometimes inappropriately call the dock-in-the-box places. These are places with part-time directors of health. They might have a full-time sanitarian and some part-time people, but they are not full-time in terms of having a full-time director of health or department. And there are actually 24 of these in the state. We also have full-time municipal departments, and there are 25 of those. We also have a health district system that's been in place since the late 1960s, where municipalities join together for the purposes of sharing public health services, and at this point we have 21. You could see that we have actually 169 towns, and we've reached a point now where we have 74 local health jurisdictions. You might notice there are 2 little red dots in the southeast corner of the state. Those represent 2 tribal nations who are not under the jurisdiction of the Commissioner of Health, but for purposes of the Public Health Code have agreed to follow the state Public Health Code. This will give you a little idea of our breakdown. Our full-time municipal departments represent full-time municipal departments represent about 1.6 million of our population, or 46%. The districts represent 1.7 million and actually 116 individual towns. And although there are 24 part-time health departments, you will notice that they really only represent 6% of the population. I want to give you a little bit of background also on Connecticut and some of these outputs that we are going to be looking at. You can see that we have a huge range in the size of our departments and even in the size of our towns. We actually only have 4 cities in the state of Connecticut that have more than 100,000 population. And if we put that together with our districts, we actually only have 9 that have a population of greater than 100,000 that they are representing. When we began to look at the services we chose them, one because they are mandated, and 2 because hopefully everybody's doing most of them, and the one that we can be absolutely sure of is food, and that's why we are concentrating on that for some of the more qualitative data. So again, quickly to let you know, this is from 2012 data. Only 3 of our jurisdictions reported no subsurface activity in 2012. All but 6 reported some level of private or commercial well activity. In Connecticut, the state is responsible for public water supplies. We are responsible for private water supplies. And again, everyone has to do food. Lead is an entirely different issue because we all know it is actually a fairly rare condition in most of our states, and it's getting rarer as we get better at eliminating it. So a lot of it's related to place and old housing, and just to have an idea of the small numbers we will be dealing with lead, there were only 107 children of the almost 74,000 who were tested in 2012 who had a level greater than 20 that required all of the full investigation and epi follow-up. So I'm going to turn this over to Jeff in a minute. We're going to talk about what are the important questions that we are looking for, and also explain why we took the avenue we did. Most of you are really concentrating on a fixed number of departments, and we decided to try to look at the entire state. We also decided to try to take an advantage of an annual report system that has been in place since 2000 in the state of Connecticut. Although we have learned that many directors of health did not fill it out very well, there's a lot of change in the variables from year to year, and that the expenditure data was never required from municipalities. However, this is a report that is filed annually with the Department of Public Health. They have actually never done anything with it, and we thought this might be an appropriate place to start looking at our cost studies, because it did include information on all of these environmental health services, the outputs in terms of the number that they did and fees, etc., as well as information on expenditures, at least for the health districts. So part of the questions we're trying to answer with Jeff's approach through the economist lens is, are some of our providers too small or too large in terms of their efficiency, and talk about the estimate of scale economies. So I'm turning it over to you now, Jeff.
Okay, thank you, Pat. So yes, so under the component 1 falls this question of whether or not providers are too large or too small, or possibly just the right size in terms of their efficiency. That's one of the questions that we've been addressing with this annual report data set that we had to supplement with some financial data that I'll talk about in a minute. The other question that we're able to talk about here is whether or not it makes sense for some jurisdictions to provide certain services or certain types of inspections individually, or to try and share some resources to do it together. And that's the issue of economies of scope. We'll get more into that after I talk about the economies of scale. But before we do that, I want to talk a little bit about sort of the approach that we use in conducting this analysis, which is the approach of a cost function analysis. And to try to give you a sense of what the cost function analysis is looking at the costs of, I want to talk a little bit about the production of environmental health inspections. And so essentially what's happening is we're taking various inputs in the production process and converting them into outputs. Just like a firm, any business or firm would take physical capital, which can consist of buildings, any equipment and structures. They take workers who are employed in these organizations and any other inputs. They combine them through the production process, and they're left with some outputs. And in our case, the outputs are inspections for environmental health, permits for environmental health, and in some situations, we're going to have other outputs because of the fact that many of these jurisdictions do other things besides the environmental health inspections. So in other words, many of the local health departments do many other things besides environmental health. That's something that is a part of the production process, and we'll talk more about that a little later. So one of the nice things about the cost function approach that we're going to use is the fact that it accounts for the districts and health departments choosing their mix of these inputs in order to balance the benefits of spending more on different types of these inputs that I described to you in the production process. So for instance, I have a little seesaw type thing here. If a district or a department would get more extra output by spending another dollar on workers than they would by spending another dollar on capital, it would make sense for them to spend that more money on workers. And they would keep doing that until the scale balances out, so that they're at the point where there's no additional benefit from shifting resources in one direction or the other. And the cost function approach accounts for this type of decision-making process. So that's one of the nice things about using the cost function approach. In terms of looking at economies of scale, we can do that by relying on some economic theory, a little bit of economic theory. And the economic theory says that the unit cost curve, which is essentially the average cost curve, is a U-shaped curve. So what we're doing is we're comparing average costs with the amount of output, and the output I described a couple pages ago on talking about the inspections and the permits for environmental health. And the incremental cost, which is just the marginal cost, is, yeah, we should probably get the pointer here. The incremental cost line is this line right here. Okay, the unit cost line is the darker shaded curve right here. And really where these jurisdictions want to be, if they're efficient, is they want to be right here at the bottom of the unit cost curve. At that point, the incremental costs and the average cost or the unit costs are equal to each other. And so if we find that they're at a point such as this point up here, in that situation, at that level, let's pick the level y sub a. If they're at that point right there producing this much output, then it's true that the average costs are greater than the marginal costs. So when average costs are greater than marginal costs, it makes sense to produce more so they can get closer to this bottom point on the unit cost curve. If, on the other hand, the incremental costs are greater than the unit costs, then they're really producing too much. And that's a situation where perhaps if they're getting too big, they have difficulty coordinating their activities, and it's just the size of the bureaucracy is getting out of control, and to such an extent where it increases costs. So if that's the situation, if the incremental costs are greater than the unit costs, it would make sense for these jurisdictions to provide fewer services. So we can use this in order to try to get a sense of whether or not it makes sense for some of these jurisdictions to share resources, or possibly to merge, or possibly whether or not it would not make sense to merge anymore because we're already seeing that we're too big or close to being just right. We'll get back into these policy issues a little bit later. The other type of issue we can look at here is the issue of economies of scope and specialization. The example I like to use when I talk about this issue to my students is, think about Thanksgiving when you're baking a turkey and a pie. Does it make sense to bake the turkey and the pie in the oven together and for one person to do that, or does it make sense for one person to bake the turkey and another person to bake the pie separately? In some sense, you might think, okay, well, you'd save more energy by putting the two in the oven together, but on the other hand, you might have somebody who's really good at making pies and someone else who's really good at making turkeys, so it might make sense to make them separately, and in terms of which is the most cost-effective approach or cost-efficient approach. So putting this in the context of environmental health inspections, this part of the figure over here says, suppose you have two different types of inspections. Okay, does it make sense to have one jurisdiction do both of these types, or does it make sense to have an individual jurisdiction to do type 1 inspection and another individual jurisdiction to do type 2 inspection? And which one leads to the lower cost? If it has lower cost to see them being done together, then it might make sense for it to be done together. If not, it might make sense for different jurisdictions to specialize and do them separately.
Like lead.
Yeah, we'll talk about lead, for instance, a little bit later, because there are some jurisdictions that don't do any lead, and then there's some that do only a few lead, and some that do a relatively larger number, not a lot, as Pat said, but it might make sense for some of those to specialize, since they're good at it, instead of having everyone try and do a little bit of it. So in order to estimate these cost functions, we need to define the outputs as well as the inputs, but one important thing to do first is to define the outputs. So as Pat mentioned, we have 4 different mandated environmental health inspections in Connecticut. One of them is for drinking water. So the output for drinking water is the number of private well permits plus the number of public well permits at any given jurisdiction in any year. And we have data that covers 2005 to 2012 annual data. Okay, so we have 8 years of data. We had, at the time this data was collected, we had 75 local jurisdictions, so we have approximately 600 data points. For food services, it's the number of inspections is the output that we use, and there are several different classes of food services that are inspected in Connecticut. So we take the total number of inspections in all those classes. For sewage, it's the number of new permits, plus the number of repair permits, plus the number tested, plus the number of B100s, which B100s make sure that there's sufficient space for a workable septic system. So we add all those up, and that's our output for sewage. And for lead, the output is the number of inspections. As Pat mentioned, it can be sparse in many jurisdictions because of the fact that it tends to be associated with older housing stock that would be in some of the bigger cities.
Or rural.
Or some of the rural places that have older housing stock as well. So just to summarize what the variables of our cost function are going to include, we're going to have the outputs in each of the 4 categories that I just discussed. We're going to have prices of inputs, which include the average wage for all workers in each jurisdiction at each year, and a price index for capital structures, which came from the economic report of the president, annual data on that. We also have a bunch of shift variables that tell us whether or not there was any nurse on staff, yes or no, whether or not we were urban or rural. Whether or not we were urban or rural, yes or no. Whether or not, or the number of patients with blood lead levels over 10, which again, this is somewhat sparse, but we decided to put that in there because it helps explain the costs of doing these inspections a little bit a little bit better than if we leave it out. We also have some indicator variables for whether or not we have a municipal health department or a district, and we compare those to the part-time situation. We also have a time trend in here in the cost function in order to capture any changes over time that happen to costs after controlling for everything else. And we also adjusted all of our dollar values. Anything that's in a dollar value, we adjusted it for inflation using Consumer Price Index from the Bureau of Labor Statistics. So this is what the cost function looks like. Essentially what we do here is we use a variation of what's called a translog total cost function. And I'm not going to spend a lot of time going over the specifics of it, but I'll just mention that what we do is we take the log of many of the variables, natural log of many of the variables, and we interact them, and in some cases we square them. And what that does is it allows for interactions between these variables that might affect costs. We also, in addition to looking at the prices, we also look at the quantities for the different outputs, and we interact those and square those as well. So the the letters Q represent outputs, the letters P represent prices, and then the D sub J, those represent the indicator variables for municipal or a district. The X represents all of the variables, the shift variables, like any nurse, urban, rural, blood level greater than 10. So the lowercase t that's near the end over here represents the time trend, and the U represents an error term. In front of each of these variables, there's a parameter that we estimate. So we estimate this cost function by least squares regression to get the estimates, the parameter estimates for the alphas, the deltas, the gamma, assuming that the error term is normally distributed with a mean of 0 and a constant variance. As we mentioned before, the coverage of this data set is annual data for each of the 75 jurisdictions from the years 2005 to 2012. So once we estimate a cost function, we can easily compute the economies of scale measure for each of the observations that we have, for each of the 600 observations that we have. If you only had one output, the economies of scale estimate would just be the derivative of the total cost, the log of the total cost function with respect to the output. And that just is the marginal cost divided by the average cost. So if you remember when we talked earlier, I showed you that picture of that U-shaped cost curve, which was like this, okay? If the marginal is greater than the average is rising as you produce more output. So that would be a point like this. So if the marginal is greater than the average, or in other words, if the estimate here for the scale economies is greater than 1, then you have what's called decreasing returns to scale. You're too big. On the other hand, if the marginal is less than the average, you're over here, okay, at this point right here, then you're producing too little. So it would make sense for you to try to do something to increase your output so you can get closer to the bottom of the average total cost curve over here. And if the marginal is just equal to the average cost, that's where those two curves intersect, then the ratio of the two is equal to 1, so that's called constant returns to scale or minimum efficient scale. That's where you really want to be if you're doing things efficiently. Okay. Now, when you have two or more outputs, it's a little bit more involved to calculate the economies of scale, but essentially what you do is you add up the elasticity of scale for each of the four outputs, and then you do the same thing. You look at whether or not that total is greater than 1 or less than 1 to determine whether or not you have diseconomies of scale or economies of scale. Now, to get scope economies, what you want to see is whether or not the marginal cost curve for one output drops when you make more of the other output. So, for instance, if you have more of one type of an inspection, does that lower the incremental cost of doing another type? And if that's the case, then that's called economies of scope. And in that situation, it would make sense to do it together, to have those two types of inspections done by the same jurisdiction. So just to talk a little bit about the data, Pat talked about the data, some of the issues of getting the completion rates, changes in data elements over the years. Those are some of the limitations. There were some missing values in some variables that necessitated us to go out to get some data from financial reports that were available publicly for some of these jurisdictions, as well as getting the appropriate outputs for some of these, because we struggled at one point, probably back in last fall when we came to Kentucky and we were talking about what are our outputs. We decided it made sense to have inspections and permits, all the outputs for all four categories, because of the fact it's like comparing apples with apples, right? If you want to add these up and look at an overall efficiency, you don't want to have, inspections as one of your outputs and something completely different for one of your other categories.
Like foodborne outbreaks.
Like foodborne outbreaks, which we were thinking about using for the food output, which has other difficulties as well. Just to give you a quick look at what some of the descriptive statistics look like, the average jurisdiction in the average year had total expenditures of about $1.5 million. The average wage was about $36,000. The price index, that's just an index that is normalized to a base year. The number of private water permits were 40. The public water permits on average were about 1.6. There were about 22 lead inspections on average in a typical jurisdiction, 434 food inspections, 256 septic. About 45% had a nurse, and about 83% were considered rural, although many of the suburban jurisdictions in Connecticut are classified as rural, even though they're not really what many of us would consider to be rural.
And they're wealthy.
And they're also very wealthy, yes, that's true. Okay, to give you a summary of the cost function results, the R squared, which is a measure of goodness of fit, is about 0.63, which says that our cost function explains, the variables in the cost function explain about 63% of the variation in total costs. And we also did a joint significant test for all the variables in the cost function, and it was highly, highly significant that these variables jointly were very important in explaining total costs. Here's what some of these elasticity of scale estimates look like, and this is basically a frequency diagram for what they look like. So if you remember, if you're on the bottom axis over here, this should vary from 0 to 1, and 1 is the most efficient. If it's above 1, it's also inefficient. But what we see here is that virtually everybody is falling between 0 and 1. We had a couple of outliers that were negative, but we attribute that to bad data, and we threw those out because of the fact that we had some issues with some data for a couple of jurisdictions, like looking like someone had hit an extra keystroke at the municipal department when they input the data into a spreadsheet or in a PDF or something. But virtually everybody is between 0 and 1 in this time frame. And what I want to do next is I want to show you how the frequency diagram, so for instance on average, it looks like the peak is around 0.2 or between 0.2 and 0.4 for the economies of scale measure. So that, again, that's less than 1. That implies that perhaps there would be some benefits to sharing resources or combining resources. But one caveat, which we'll get into in a little bit, is the fact that for some of these jurisdictions, when we had to go and get their financial data, what we realized is that they report their total expenditures, some of them, for all the services they provide, not just for the 4 environmental health services. So in some sense, the total cost might be overstated, which means that they're really high. They're appearing to be higher up on their unit cost curve, on the U-shaped unit cost curve, than they actually would be if we had only looked at environmental health inspections. So perhaps this whole thing would be shifted a little bit to the right if we were able to obtain data that was just exclusively for environmental health services. And we'll talk about how we might try to do that in a little bit. For the districts, it looks like the center of mass is around 0.4 for the elasticity of scale, which implies that they're a little bit more efficient on compared to everybody overall. The municipal health departments are a little bit less efficient. Their center of gravity is about 0.25. And once again, that may be because for many of the municipal health departments, they do a lot of other things and they're really big, and that may be capturing some of that in terms of what looks like inefficiency that may not really be inefficiency. And then for the part-timers, their center of gravity is even further to the left than the municipals and the districts, a little bit less than 0.2. That makes sense because of the fact that these guys are very small often and doing a lot of things that could perhaps be done better if they were to combine resources with other jurisdictions. And a lot of them, you have to pay for some of these fixed setup costs to get things going, and when they're not doing a lot of output, it may not be the most efficient way of doing things. I just want to show you some graphs, and I'll go through these quickly, that plot the elasticity of scale versus the total output. The total stuff is what the total output is. To show you that the jurisdictions that do a lot of stuff, that do a lot of inspections, tend to be more efficient. Their elasticity of scale approaches a higher number, closer to 1. And I'm just going to go through these fairly quickly to save on time. Municipalities, we also see a positive relationship between their output and their measure of efficiency approaching 1. Same thing with the districts as well. We also did this for the part-timers, and so we see for everybody, essentially, the more inspections that they do, the more they approach the elasticity of scale coming closer to 1. If we compare the total costs for all the jurisdictions with this measure of efficiency, once again, we see a positive relationship. If we look at the municipalities, we again see that positive relationship. For the districts, it's a pretty flat relationship. And these red lines, by the way, are essentially just regression lines, least square regression lines, to try and look at the relationship between these things. So for the districts, having higher costs doesn't necessarily, having higher total costs, not unit costs, doesn't necessarily imply that you're more efficient in terms of your unit costs. For the part-timers, however, having higher costs does tend to imply greater efficiency. And we're going to try and also look at population in this context as well to see how higher population might lead to more or less efficiency in this context. We also, one other measure of size we looked at was full-time equivalents. So we see that if you have more full-time equivalents, you tend to be more efficient, so, or at least approaching the level of efficiency of 1.0. And this is true for the municipal health departments, the districts, and the part-timers as well. So that's the analysis of elasticity that we looked at. So now I want to move to the scope, the economies of scope or specialization analysis. So yeah, as I mentioned before, how does doing more of one type of inspections affect the incremental cost of other types of inspections? And this is important if you're thinking about sharing services or thinking about merging. It's important to consider. If this relationship is positive, then more of one output increases the incremental cost of another. So it makes sense to specialize and not to combine your resources. If it's negative, then more of one output decreases the incremental cost of another, so it makes sense to do these things together. What do we find? We find that water and septic would be more cost efficient to be together. Water and lead, on the other hand, tend to do better separately. And with this measure of economies of scope, you're really only able to compare 2 at a time. You can't compare 3 against each other. That's one of the potential limitations. But water and food, it would make sense to specialize. Food and lead, it apparently makes sense to do those together. Food and septic makes sense to do together, and lead and septic makes sense to do together. So one of the things we were thinking about is, why is this the case? So for instance, if you're a district that does many food inspections and few of others, and then there's another district that does many lead inspections and few of others, you might see that there's cost savings from merging or sharing resources if your economies of scope estimate is negative. On the other hand, it might make sense to not merge or not share if this estimate is positive. So if we're looking at lead in food, for instance, we see that the estimate of economies of scope is negative. So therefore, it would make sense for those 2 jurisdictions to share resources, for several jurisdictions to share resources in order to try to capture those scope economies in that situation. So what are the limitations of our analysis? Well, one major limitation is the data, which Pat already touched on. We could talk for a long time about the data, and in fact, when I first joined the project, I thought the data would be a lot worse than it was, but there still are some serious issues with the data in terms of responses, non-responses. We had to go out and gather much more data from the annual reports that the finance departments in a lot of these places were putting out. Many of those were in PDF form, and we could see in some of those, from time to time, there were things that looked questionable. But some of the other issues include the economies of scale estimates. Those depend on small changes in output. So if you're looking at 2 fairly decent-sized jurisdictions and you're trying to say, okay, let's use this analysis to say that we should merge those 2 jurisdictions, you might have a problem, because really, if you suddenly double your output by merging 2 large jurisdictions, you might go from being on the left side of the bottom of the U-shaped curve to being on the right side of the bottom of the U-shaped curve. So you really have to only look at small changes in output. So really, this would be most applicable. The fact that we see these efficiencies from sharing resources would be most applicable to a situation where you have part-timers, for instance, where they're not doing a lot already, and so increasing their output would have a less likelihood of pushing them to the wrong side of the unit cost curve. As I mentioned with the economies of scope measures, this assumes that all the other types of inspections are being held constant. So you can only compare 2 at a time, holding everything else constant. So you can't, even though many of these jurisdictions do at least 3, and in some cases they do 4 if they also do lead, you can only do pairwise comparisons. So you have to be careful in that situation about trying to make overall generalizations about whether or not things should be done together or things should be done separately. But nevertheless, in some situations where some jurisdictions do 0 of some things and others do a lot, and you might be able to use that as some basis of comparison.
Particularly if what you're doing, like lead, is very costly in human resources and time and the effort that you have to put into it.
Yes. So one of the other limitations is that, as I mentioned, many of these departments and districts offer other services. We're only able to control for the environmental health outputs. So the output might really be understated from what they're doing. So perhaps they're really further down on these U-shaped unit cost curves than we have found. And that's another potential limitation as well. Some of the policy implications of what we're talking about is that there can be some drawbacks from encouraging jurisdictions to merge or share resources because of, as I mentioned before, this elasticity of scale estimate assumes only small changes in output. And then you might be seeing some jurisdictions that are experiencing economies of specialization for certain types of outputs, so it might not make sense to combine these jurisdictions in that situation. On the other hand, there are some efficiencies to be gained from merging small jurisdictions, such as the part-timers, and some of those may also just happen to benefit from the economies of scope for some of the outputs that they happen to be producing. So just to conclude, and we want to leave a few minutes for discussion, what do we suggest, what would be a fruitful area for future research is to have a supplemental survey to these annual reports. And that's what we're going to be doing going out next and going back to some of these jurisdictions and trying to get more, to hopefully all of them. We're going to try to go to all of them and try and get some additional information in order to try and isolate what these outputs are for the environmental health services. And hopefully that will be useful to us in order to calculate the actual unit costs for each of these services, for each of these inspections. And we're also going to conduct some focus groups for component 2 of this analysis that we saw at the very beginning of the presentation, some key informant interviews for component 2. Pat, you want to talk very briefly about those?
Yes, as I mentioned, this is much more qualitative, and so these are going to focus on food service, again, because it's what we know everybody has to do. And the focus groups will actually be qualified food operators and restaurant managers from the end user of all our licensing and inspections to really get at some of those efficacy, efficiency, and equity issues. And then there will be key informant interviews with chief sanitarians and directors of health to really scope out the practice of food service protection program and look at all of the different parameters that we are interested in.
Okay, so that's the end of our presentation. Would you like to take control back of the...
CB, it's all yours.
Well, Jeff and Pat, thank you so much. You know, we really enjoyed that presentation. I think it was really helpful, and you guys did a great job in really just showing how you move from presenting and explaining the economic theory of economies of scale, economies of scope particularly, and you know how it works in evaluating the efficiency of these food service environmental health inspections, and just showing how you operationalized it, you know, using the data on hand that you had, the available data. I liked how you did the empirical analysis, pretty straightforward, and particularly I think the data visualization was very helpful, and just the indicators of whether, you know, there's inefficiency and whether there's economies of scale or scope. I think that was very helpful, and particularly towards the end, how, you know, you discuss, you know, just the implications are pretty clear for using the results and guiding, you know, for organizational policy, administrative related decisions with regards to whether or not to merge or combine resources between two departments or not, or to, you know, to keep them separate. I think that was very helpful from your presentation. So before I continue, is there anyone who'd like to ask Jeff and Pat any questions about their study? The line's open.
Maybe we put them all to sleep.
No, I think there's just so much there to digest, and I'm sure there's a lot of great examples. I think particularly how you just operationalize being able to measure, you know, economies of scale and the economies of scope. I think we often talk about it, but just to see an actual empirical example, that's going to be very helpful moving forward. I'd like to, I guess, just ask you guys a little something more about, you know, you talked about really the data limitations, and before I turn it over to Lizette, because we talked about this when you previewed the presentation to the National Coordinating Center, how, you know, as, you know, the different PBRNs try to carry out their DAC studies and trying to estimate these costs, and many of them, you know, the first step is to try and look what the available secondary sources of data are based on whether if it's a statewide reporting system or just what the current system of how local health departments now, you know, either report both outcomes and, you know, their expenditures. and how there's just a lot of limitations in the way these things are currently reported, that it makes it really difficult to come up with accurate estimates of, the cost of delivering public health services or these different activities and programs. Do you see, it would be helpful, I think, in your study and in all the studies of the other DAC studies to present recommendations of how to improve, how local health departments or state, health departments report these expenditures and these measures and outcomes and indicators. Any thoughts on that? Just a little preview of what you would write in your report.
I think your point is well taken, and I'll address, and then I'll let the economists also address it. Many of us are used to reporting budget data and not expenditure data. And as soon as we begin to work with the economists, they need real expenditure data. And clearly, one of the major shortcomings of our study is, in many cases, particularly for the municipalities, because it wasn't expected from them in the annual report, all we have is cost of total services. So as you and I have kind of discussed before, there's an assumption of proportionality here that is not true. And I frequently looked at my own health district when it kept popping up as this bad outlier, and realizing that I had school nurses and I had over 25 staff who had nothing to do with environmental health. So our approach isn't going to work for something like that, and we are in the supplemental survey really going to try to see if we can get the directors to help us estimate what proportion it is. So in many ways, the approach other people have taken, where they actually go sit in the office with you and go through everything, may be what we all have to do in the future. Because I don't think there's any standardization about how states collect data, but I do think that if we're going to look to external data, then there has to be some agreement on what you need to be collecting.
Yeah, I'd just like to add that the data that we used, some of it came from State of Connecticut DPH annual reports that were in a database that nobody had ever looked at.
Verified or anything.
Then it required a lot of cleaning up, and then once we did that, we realized we needed more. And so we, as I mentioned, we had to go to Finance Department public reports to get some of that additional data. We also had to go to the states. The state DPH also put out lead reports, which we had to, and that's by town, not by district. So we had to, then put that into the same format of the same boundaries as the jurisdictions. Some of them are obviously consist of more than one town, and so we had to deal with that. So there were a lot of data issues, and then once we got into the state's annual financial reports, the state DPH financial reports, we found issues here and there, lots of little things that had to be cleaned up and dealt with. So moving forward, to get to your question, CB, I would say it would be extremely helpful if there were some statewide effort to try and keep this data set more maintained and keep it in, or gather the different parts of the data and follow up on them. Don't just take them and put them in a database and on the shelf somewhere and never look at them. Try and encourage people to use this and work on it so that public health researchers can benefit from the quality of the data. There is a lot of data out there in Connecticut. It just wasn't easily pluggable into a regression package. You had, we spent many months trying to supplement it and clean it until we got to the point where we were able to do what we showed you today.
Correct. So I expect a lot of this to be documented in your technical footnotes in your study or in your final report. And I think it just speaks to,
definitely will.
Yes.
Yeah, and I think it speaks to all the experiences of the different DACs grantees and the different PBRNs. Just so much limitations in your data sets or the existing available sources of data that it's important to document the process by which you try to improve on it or try to work with it, because that forms the basis for the recommendations that you have in improving these reporting systems, and in order to provide data that can be useful for public health, research. And but anyway, we've got other items on the agenda. So once again, we'd like to thank you, Pat and Jeff, for that excellent presentation. Very helpful. It will be very helpful for the others too as well. And if you have any questions that you'd like to add on, please feel free to either send them a direct email, or you can also direct it via the National Coordinating Center. So once again, congratulations, and thank you, Jeff and Pat, for your time in presenting.
Well, thank you for your comments and support as well.
All right, so Lizette, you have the floor.
Thank you, CB, and thank you again, Pat and Jeff. We really appreciate that. So now moving on to some PBRN research updates. First, I'd like to congratulate the PBRN presenters at the NACCHO meeting. I just had a brief look at some notes that Kara provided for me, and it looks like we might have had some Washington, Georgia, Kentucky, and North Carolina PBRN representation at NACCHO. So congratulations to you, and as always, a reminder to please send me products. Those presentations at NACCHO are considered products of your grant, so please send those to me. Moving further along, for those of you who are going to be in New Orleans in the fall, we do have an Improve in DAX panel at APHA, and that's November 18th, 10:30 to noon, and I believe that it's going to be the Florida, Minnesota, Connecticut, and Colorado networks, so please be on the lookout for that. I just wanted to update you where we are on the directive proposals. We have sent our recommendations to the foundation, and we've been working through some budget negotiations on those projects, and hopefully we will be ready to make some announcements pretty soon. As you know, we can't say anything about those until we get the final okay from the foundation, so we look forward to that happening very, very soon. Additionally, the quick strikes, we have finished all of our review process. We've provided some feedbacks, and we're also again in the process of doing some reevaluations of those, and we should be able to make final announcements on those really soon as well. Again, the next item is just another reminder to please submit your Academy Health and NACCHO presentations as grant products. As you know, many of the DAX projects ended, or a couple of the DAX projects ended on Monday, and so I was very thankful for everyone sending in their products for those. If you have not done so, please go ahead and do that. The next item I want to discuss is the grantee meeting, and it's really a grantee workshop, so consider that a typo. It's a grantee workshop that we're going to have here in Lexington on August 11th and 12th, Monday and Tuesday, and I would like to thank everyone who responded very promptly to Calvina and have made your flight reservations. We are truly thankful that you did that on time. Again, our apologies for the tight timelines on this, but as you know, our grant, our technical assistance and proposal grant ends at the end of August, and so we need to make sure that we invoice all the costs for this workshop before the end of the month, and so we're going to be very tight on turning things around and perhaps not being able to reimburse you for things that require receipts like we did before. But we are covering almost all of your meals and providing per diems ahead that will determine, so we hope that you won't have too many expenses on your own. And just a little bit more about the makeup of the workshop. So as you know, it's a 2-day workshop, and on day 1 we're going to focus on findings or emerging findings and translation and dissemination of those findings. We are going to be joined by a couple of the PHSSR Mentored Research Scientist Development Award grantees, and then of course the PBRN Improve and DAX grantees. We're going to have you present short 10-minute presentations, again focused on findings and translation and dissemination, and geared towards a policy audience. So, maybe one slide on methods, but mostly on translation and dissemination. Remember that, this is all inside our PHSSR family, so your presentations are to be considered in we're going to be able to provide a lot of guidance on how best to present to policymakers. So again, very short presentations specifically geared towards findings, and dissemination towards a policy audience. On day 2, we're going to move again away from translation and dissemination more towards methodology. And here's where we're going to use the results for Improve and DAX to transition to the directive proposals. So this second day is going to be slightly different. So it's going to be more of a plenary where we have the morning session where we're going to look at measurements based on the delivery side. So this would be, perhaps mostly the Improve experience, whether looking at strengths, limitations, and lessons learned. And then in the afternoon, we're going to move to measurements on the cost side, again, looking at strengths, limitations, and lessons learned, which is exactly what Pat and Jeff were talking about today. We're going to look at analytic approaches for analyzing patterns of variation, and of course analysis to determine cause and correlation. So again, we want everybody to be prepared to talk about their project. You won't have to have any formal presentations on this day, but perhaps have a one-page document that highlights some of these items that I discussed. And we will be providing you all of this written information. Again, we are working on the agenda as quickly as possible, so we will provide you some information ahead of time, and you can talk to me or CB or Anna about what's expected of you as an improved DAX, and hopefully by then directive grantee. Any questions on that? Okay, so moving on, in our next month. Yes.
Oh, sorry. I think Tracy had a question. Which grantees are invited to this August meeting again? Just to clarify.
Oh, sorry, I didn't hear you. These are all of our grantees. So the Improve, the DAX, and the directive. Most of the directive proposals or grantee, hopefully grantees to be soon, are invited to this. I think we have heard from all of the networks. If you have any questions about this, please contact me after the call and we can discuss. Any other questions? Okay. Yes, actually, Tracy, I see your message now. I believe that I'll have to look and see who's coming from the Wisconsin PBRN. We will also have, so next month is our August 21st meeting will be the Colorado PBRN, and we will also have some time for teachbacks for the Academy of Health scholarship recipients, and we'll get information out to those folks before in a couple of weeks. And then the last item I'd like to mention here is our collaboration with JPAL on pragmatic randomized controlled trials in public health settings. JPAL is the Jameel Poverty Action Lab, which is a research center at the economics department at MIT, and they are looking at pragmatic randomized controlled trials in public health settings, and of course we're very interested in that. We have two examples of PHSR studies using randomized controlled trials. One is a Kentucky PBRN study that said that she confirmed with their, sorry, it's the assessing and improving culturally linguistic competency in local health departments, and this was the RACE grant for those of you who remember. So this study randomized local health departments into two groups, one which received a culturally and linguistic training designed to increase the use of culturally and linguistic appropriate services in local health departments, and the other one which did not, and then they evaluated the impact of that training program. Another study, also a PHSSR study, but it's not a PBRN study, but it was a PHSSR study, is an example from the University of Colorado and Colorado Children's Hospital. And this trial tested the cost effectiveness of a novel strategy for increasing childhood vaccination rates using a reminder and recall intervention delivered centrally by local health departments and in collaboration with community-based primary care practices. This is a very interesting study that was presented at the Academy of Health ARM meeting for those of you who went. And again, the goal of these trials is to generate hard data that can then be provided to policymakers for decision making. And this is exactly where we want to go with the directive work. There was a recent article in the New York Times that I did want to highlight to you, and let me find the link here, and I'll copy it and put it on the window because it's a very interesting article that specifically addresses this for policy making. So you should see it there in the window. Let's see, next item. CB, do you have anything else to say about JPAL?
You got it covered. No, yeah, nothing.
Next, some dissemination opportunities. As you know, the 7th Annual Conference on the Science of Dissemination and Implementation in Health is coming up. Well, it's not till December, but abstracts are due August 8th, so that's pretty soon. Registration is finally open at the Academy Health site. If you click on the link that was sent on the agenda, you'll be able to get to that registration site. The next item, to please advise us of any upcoming conference presentations and or practice or policy translations that you're planning, because we really want to be abreast of this type of work that you're doing in your networks. Also, I'd like to remind you that the PHSSR 2014 solicitation is coming to a close on July 23rd. I know a lot of you are furiously preparing proposals for that, so just a reminder for that, there's still time. And with that, just a last reminder that Colorado will be presenting next month, and that we'll have the Academy Health annual research meeting and interest group teach back presentations during our next month. Any questions? Okay. Hearing none, CB, do you have anything else to add this month?
No, I think, Lizette, you've got it all covered, and we look forward to the August 11 meeting.
Yes. Okay. Thank you very much, everyone. We appreciate your coming to the meeting, and congratulations to Connecticut. You did an excellent job. And be on the lookout for information for the grantee workshop in August. Thank you.
Thank you.